The vast majority of women and doctors are making their hormone therapy decisions based on fear and, misconceptions. And the fear of breast cancer is largely driving women's access and decision-making, as well as doctors. And that's all because of the Women's Health Initiative. And that has left a legacy of fear and misinformation that has left a generation of women and doctors feeling really uncomfortable and nervous.
It isn't about being perfect. It's about being better. Hello, my name is Dr. Stephanie Estima, and I host expert discussions with thought leaders in all facets of health, including nutrition, fitness, hormones, stress management, performance, recovery, longevity, health span, and energy production. On this show, we discuss complex science, but then we also alchemize it into actionable, everyday living. The ultimate goal with the show is to assist you in making informed decisions about your health and to catapult you into being the hero in your own life. Hey, Betties, welcome back to Better with Dr. Stephanie. It's me, your host, Dr. Stephanie Estima. Today, I am talking with Dr. Corinne Menn, and we are talking all about hormones, breast cancer, vaginal estrogen, you name it. Dr. Menn is a board-certified OB-GYN and Menopause Society certified practitioner. She is a 20-year survivor of breast cancer and premature menopause. She's a BRCA carrier, BRCA carrier, and she uses her experience to help women navigate their own health challenges. She has dedicated her medical practice to menopause management, the unique healthcare needs of female cancer survivors, and those at high risk for breast cancer. She now practices exclusively through telehealth through Alloy, and she provides women's health consultations and patient education via her private practice at Alloy. So, what did we talk about today? As you might guess, we talked about the Women's Health Initiative, the WHI, and we get into some of the shortcomings that happened from, or conclusions that came from that study. We also moved into breast cancer risk and hormone replacement therapy. So this is it's sort of niche, but I feel like this is an important conversation because every woman, maybe their mother, family member, community member, you're going to know somebody who deals with breast cancer in your lifetime. So knowing how to navigate it, especially if you are perimenopausal and menopausal, I think is very important. We talk about best case scenarios for use of hormones, worst case use for hormones, and much more. And then we move into vaginal estrogen and the genitourinary syndrome of menopause. It's not just for lube, ladies. You'll want to listen to what she has to say about that. And then we also get into the timing hypothesis. Those of us who maybe have missed the window of opportunity or the best time to get on HRT, what is available to our 60, 70, and 80-year-old women. I really feel like this is an important conversation. Dr. Menn did not disappoint. If you want to hang out until the end of the show, what I'm calling the after party, you're going to hear my best takeaways, my favorite parts of the conversation, and maybe not so favorite parts of the conversation. So without further delay, please enjoy this episode with Dr. Corinne Menn. All right, Dr. Corinne Menn, welcome to the show.
Thank you for having me. Excited to be here.
Yeah, we're going to talk about hormones and menopause, and we're going to really focus in on breast cancer today, because this is maybe a very common question that I get, probably one of the more common questions that you get, or one of the more common issues that you have advocating for the patients that you see. And I think maybe to orient ourselves, it might be useful just to think about where this misconception or overly cautious, we'll say, philosophy around hormones and breast cancer came from. So we have to talk about the WHI, the Women's Health Initiative. So I'll let you start the conversation off by talking about maybe some of the shortcomings in terms of population selection for the WHI, so who was included in the study, and then some of the different arms that they looked at in the study, so the estrogen-only arm, and then the type of interventions that were used and why those are a little bit different, very different, than the hormonal interventions typically offered to patients today.
Of course. I always say this, that the pink elephant in the room is that the vast majority of women and doctors are making their hormone therapy decisions based on fear and, misconceptions and the fear of breast cancer is largely driving women's access and decision making, as well as doctors. And that's all because of the Women's Health Initiative, which was a very important study. We're not about to throw the baby out with the bathwater. We learned a lot of good things, important things from the Women's Health Initiative, which was the largest to date study ever done on hormone therapy in women. But there are huge problems with the way the results of that study were messaged to the general public as well as to the physician community back in 2002. And that has left a legacy of fear and misinformation that has left a generation of women and doctors feeling really uncomfortable and nervous about using hormone therapy, primarily because the message that went out, kind of the soundbite, was that estrogen causes breast cancer, and it also caused all these heart problems. So it's dangerous. You should only use it if you absolutely have to. And because of that message, physicians who were in training at that time, I was a second-year OB-GYN resident at the time, really just didn't get any education on actually the science of hormone therapy. And there was already a lack of education on the physiology of menopause in general. And that was like the nail in the coffin. There was just literally no interest in really pursuing that. So here we are now, fast forward over 20 years later, right? Where just a generation of doctors and women are misinformed. But here's the facts about the WHI study that are really important for women to understand. First of all, it was already established that estrogen and hormone therapy was FDA approved for the treatment of hot flashes and night sweats, so vasomotor symptoms, lowered the risk of osteoporosis. We knew it treats the genital urinary syndrome of menopause, and, was also used for women who went through menopause early. And it had been well established and, used for decades, right? It was one of the most commonly prescribed medications. The interest arose because there was a lot of data, a lot of observational data showing that hormone therapy may be also protective from the cardiovascular system. And so they wanted to test that hypothesis. So essentially, the WHI study was not whether hormone therapy was safe or not. It was already determined to be safe. It was whether this would be something that we can use for primary prevention for heart disease. So it was really, that was the primary outcome that they were looking at. And so in order to get that outcome and, and get some meaningful results, they had to recruit older women. Right. And they had to recruit women who no longer had hot flashes or night sweats, because otherwise they would know whether they were on hormone therapy. Right. Because otherwise it couldn't be placebo controlled, because you would know if you were getting the hormones if your hot flashes went away. So it's important to keep that in mind. So the population of the WHI was, in general, an older population than the average woman seeking menopause therapy, which is women in the late perimenopause stage, and normally women within the first 5, certainly 10 years from, menopause. That's the average kind of woman who's seeking it now, right? So these were older women, and on whole, they were, they did have elevated cholesterol and elevated blood pressure. They were older, they were less healthy, right? But even with this older population, and we should say they separated these women in 2 arms. If you had a uterus, you took an estrogen plus a progestin. And if you didn't have a uterus, you didn't have to use a progestin, so you used estrogen alone. And fast forward, they stopped the study short, and they held a big press conference that said it causes breast cancer and there was an elevated risk of cardiovascular disease. And that went out like a lightning rod to the world. Everybody got scared. But the facts are that the women in the estrogen-only arm of the study, never showed an increased risk of breast cancer. At that initial press conference in 2002 and on subsequent follow-up. And at the 20-year mark, they were found to have a lower risk of ever getting breast cancer by roughly about 23%, and up to a 30% decreased risk of dying of breast cancer. Okay? So let that sink in. The estrogen-only arm, no increase, actually a lower risk of dying of breast cancer. Estrogen-only arm. The progestin-only arm, those women had the other arm was estrogen and a progestin. And that arm of the study showed a slight increase, statistically not significant, reaching statistical, not quite reaching statistical significance, but they reported it as though it was statistically significant. But let's just take them at face value and say we even believe that it was actually an increased risk. The increase was an increase in incidence of breast cancer, okay? And it was less than one additional breast cancer for every 1,000 women taking it, right? And on the 20-year follow-up, it showed there was no increased risk of dying of breast cancer. And that increased risk was similar to modifiable lifestyle risks like having obesity or, drinking, excessive alcohol intake, right? And so that is really not the message that was sent out to the public. The message was that estrogen causes breast cancer, right? And that is not what the WHI study found. And in fact, the WHI primary investigators have now walked back all of their, original claims. And, they say like we should never use the WHI to withhold menopausal hormone therapy access to women out of fear of breast cancer. But old habits die hard. And, so that's kind of the background. If you want to learn more about this, the best thing you could do is pick up the book Estrogen Matters by Carol Tavris and Avram Bluming. And that really explains it in detail for the layperson out there or the doctor out there who's kind of confused by all this kind of different arms of the study. And that really puts it in clear perspective. And then, alluding to what you alluded to the different formulations. And so it's important to remember in the WHI study, they used conjugated equine estrogen, all right? That's Premarin. And they used a synthetic progestin, medroxyprogesterone acetate. And remember, we should not fear conjugated equine estrogen. And I know for a variety of reasons, which we can talk about, these days we prefer really FDA-approved bioidentical estradiol. That's what we generally prescribe in hormone therapy. But conjugated equine estrogen is frankly the only estrogen that's been studied in such a large study like the WHI that actually showed a significant decrease in getting breast cancer or dying of breast cancer. So we should not fear conjugated equine estrogen when it comes to breast cancer risk. And we shouldn't fear estradiol because neither have ever shown to cause or increase your risk of breast cancer. Now, the medroxyprogesterone acetate was an old synthetic, progestin that is still used and is useful in very specific cases. It can thin out the lining of the uterus well, can help control bleeding. So we use it for specific things. But in general, we don't use medroxyprogesterone acetate in hormone therapy anymore. And in fact, we now use bioidentical FDA-approved progesterone in the vast majority of cases, or one of the other synthetic progestins. And when we compare those progestins, we see that medroxyprogesterone is probably the least beneficial on breast tissue, right? There's more inflammatory response to it. There's other aspects of medroxyprogesterone acetate that are, kind of less ideal on breast tissue. So I always like to come back. What is the worst case scenario in terms of risk? If I prescribed you a combined, basically what Prempro, is the conjugated equine estrogen with a synthetic progestin, what does the data tell us? It tells us that even with that old school formulation, your risk of breast cancer incident appears to be similar to modifiable risks like I mentioned, like alcohol intake or, unhealthy lifestyle or, having obesity, right? And that risk is less than one additional person for every 1,000 women taking it. And we must weigh that against the many benefits of hormone therapy, including prevention of osteoporosis, right? 1 in 2 women will suffer a fracture in their lifetime, right? And we can get into those details. Symptom relief, quality, of life, better sleep, all of these things, right? So you're more than just your breasts. That's the other thing to, remember. And then the last thing that gets a little bit into the weeds, but, there is serious criticism of even that risk associated with the synthetic progestin. Dr. Avram Bluming published an incredible piece along with colleagues and many other leaders in this space have deeply criticized how the WHI interpreted their own statistics and that it didn't actually reach statistical significance. So that's why I say worst case scenario, if we even believe them at face value, it's still such an incredibly low risk. And we can modify that by choosing to use progesterone and, and really looking at the full picture of the woman, right?
Beautiful. Beautifully said. Let's just, again, just for definition's sake, I get a ton of questions on what is the difference between a bioidentical, so you've mentioned now bioidentical estradiol, bioidentical progesterone. What is the difference between that and a synthetic hormone? And I know that there are some educators in the space that feel like bioidentical is a marketing term. They sort of dismiss it. Can we give some verbiage into how we distinguish between those two camps?
Well, I think it's dismissive to say that it's only a marketing tool, but I understand in part why they say that. So let's just talk about what does bioidentical mean? It just means from a biological structural standpoint, it's literally the same hormone as what your body's producing. So estradiol, right, looks exactly the same that's produced in your body as an estradiol patch, spray, gel, vaginal cream. And then progesterone, right, looks the same as what your body is being produced, right? So that's all it means, that it looks the same, right? Now, the reality is none of these hormones that we're prescribing to you magically just appear out of nature in a pill form. They're all,
You don't pluck it off the progesterone tree, Doc?
No, we don't pluck it off the progesterone tree, right? We are harvesting it from women, right? So they're all made in labs. Are they natural? They're made in a lab, right? And typically they do use plant-based, molecules that help them generate this in a lab. Now, the marketing thing, the important thing is that some women are led to believe that the only way that they can get bioidentical hormones is if it's compounded from a compounding pharmacy. Compounding pharmacies have important roles. And, there are, hormones that are available from a compounding pharmacy as well as other medications. And then there's FDA approved, really well studied, quality controlled hormone therapy and other prescriptions available, right? And so when women are led to believe that the only way for them to get bioidentical hormones is through a compounding, right, or through a pellet, that's not true. And I think that's where the criticism about marketing is. And so you can go to your local CVS or regular pharmacy and get bioidentical estrogen or estradiol and progesterone. Okay. So that's important. And I also think it is important. We need to recognize that in general, from a safety, tolerability, and probably efficacy in terms of getting, the best results in terms of symptom relief and maybe other things like, bone protection and such, it appears in the literature, although we need more studies, right, that the bioidentical estradiol and progesterone are probably going to do the best job overall. That being said, I never want women to fear if they need to use a synthetic progestin for whatever reason. Some women don't tolerate progesterone. We need to use an alternative progestin. And we don't want women to be afraid of, safe, well-studied hormonal contraception. And, birth control pills have to be synthetic at this point in time. That's what we have because it has a different job. It has to suppress ovulation, right? And it's also can be used, to control, heavy menstrual bleeding and such. And sometimes these tweaks that are made in these synthetic hormones help it do a better job. If we had to give you very, very large doses of bioidentical estradiol and progesterone, enough to suppress ovulation, you probably wouldn't tolerate the side effects, right? So we don't want to vilify the right appropriate use of synthetic hormones, but also we need to recognize and be honest that there's a reason why we now these days prefer bioidentical. And in my opinion, we try to use FDA approved options when we can. And when we need to compound things, we lean on, a reputable compounding pharmacy and make sure that we're choosing good products. So
the one thing that every time we discuss the WHI on the show, one of the feelings that I constantly get is I'm overwhelmed with what appears to be just like a disinterest for whatever reason. And maybe you have some insight that I don't, but there just seems to be this disinterest in caring for women well. I know that there's always been jokes, and I've said this myself, that, if a man, if there was an equivalent in the male population, and we just said, well, honey, it's just because you're 45, it's just because you're 55, like that's just what aging is, like eat less and move more. Like maybe you just need just pottery. Like, do you want to take a pottery? I feel like this, and I'll ask you to elaborate on this, but I just get this overwhelming sense that there's this disinterest in serving women well. I don't know if it's intentional, maybe it is, but managing menopause and believing women when we say, hey, we're suffering. There are, and it might not necessarily be the hot flashes of the night sweats, like sort of that classic symptom cluster of perimenopause. It could be just mood and affect changes. It could be, burning, itchy skin, like some of these sort of, atypical, we'll say, are not commonly accepted symptoms of menopause. What say you?
Listen, we have to recognize that for centuries, right? Women's health has not been, elevated or respected in the same way as men's health. We know that women were not included in were required to be included in trials of medications in the US, right? Until recent years. And, the emphasis in women's health, right? I'm an OB-GYN. So the emphasis in women's health in my training is on pregnancy, on reproduction, and then on obviously the surgical management of things that, cause suffering, like, endometriosis, fibroids, cancer, right? That is the primary, focus of an OB-GYN residency. And I think in general, we have to admit that in society, women's sexual health, her kind of wellness and her health after her reproductive capacity ends has never been really valued. We're kind of sent up to pasture, kind of this older woman menopause. And in fact, I think that's where there is a lot of shame around women even admitting or talking about menopause, because it seems like kind of like, I hate to say it, but women feel embarrassed to talk about it, shameful. Oh, you're old, you're dried up, you're not sexy anymore, right? And we'll talk about this in a little bit. I know we're going to get into breast cancer, but and this is why for women who deal with premature menopause due to cancer treatments or for any other reason of having premature menopause, there's lots of reasons why it can happen early. It's particularly shattering. Because imagine being in your 20s or your 30s and identifying as menopausal. Like, that's really uncomfortable because in your mind, you picture someone old and no longer kind of valued as a woman in terms of what society thinks. Now, luckily, that narrative is shifting, thank goodness, to powerful leaders and women in this space, and women rising up and saying, hey, I've got another 50 years to live. I deserve to live well. I'm not dried up. I'm just getting started, right? But it really comes, I think, down to like just admitting societal biases on women and aging and the lack of training. Listen, I had zero education in menopause in my residency training, none. Right. There was no menopause clinic. We touched on premature menopause and, some little basics here and there, but there was nothing about managing menopause. And then, it was the second year of my residency when the WHI hit. And so if there was any interest in prescribing hormone therapy or even talking about menopause, it was halted then. Right. So I think that's, but this is the first generation of women who are in their 50s, who are coming into that menopause transition, and they're in positions of power, right? They're physician leaders, they're leaders in media, in television, in Hollywood, and so they're speaking up. They're like, I've got a voice, I've got leadership roles, I'm an entrepreneur, I'm a business person, and I'm not going to take this, so, and it's the first generation of women going through menopause during social media. So we have now a way to democratize getting the word out. We've got podcasts, we've got social media. And so women, the change is happening, I say from the ground up. It's women becoming knowledgeable about their bodies and what they want for their health. And they're rising up and they're demanding of their physicians, like, hey, you need to address this. And then the physicians are like, ooh, I need to learn about this, right? And so that's what's happening, really.
Okay, so let's shift to breast cancer, because I think even though you very eloquently explained the results from the WHI, there's two problems. One is, I think, patient understanding, and then two, I think, is the oncologist understanding of what's going on. Yeah. So with breast cancer and HRT or MHT, so hormone replacement therapy or menopause hormone therapy, a lot of people will say, and I've heard this is questions that people ask, well, my cancer was estrogen positive. That's sort of the the nomenclature that they'll use to describe their cancer. So I just want to spend a moment talking about language, if we can, because
Sure.
language is important. Yes. Does that mean when someone says, well, my cancer was estrogen positive, does that mean that it's estrogen that caused the cancer?
No, and I think it's important to understand this. So all cells in your body have estrogen receptors on them. And I think this is important for women to understand. And this really is something that is never explained to breast cancer survivors. So every cell in your body has receptors to estrogen, to progesterone, to androgens like testosterone, right? So that's just a normal part of your cells, okay? And it's not just your breast tissue, it's your uterus, it's your brain, it's your skin, everything, right?
Lungs,
everything,
yeah.
All right?
Yeah.
And so normal, healthy breast cells have these estrogen receptors and progesterone receptors, right? And from the time you're a little girl through puberty, pregnancy, lactation, perimenopause, menopause, those cells in every part of your body, not just your breast, those cells, those little estrogen receptors are responding and changing and doing different things depending on the rise and fall of estrogen, right? So estrogen receptors are a very important integral part of the physiology of your cells, right? So now fast forward, you get diagnosed with estrogen receptor positive breast cancer. Okay, it's very important to understand that receptor is important, and it's very important that we have discovered that some breast cancer cells, actually the majority of breast cancer diagnosed in the world is ER positive, so estrogen receptor positive, and those cancer cells, right? Your cancer has it's retained that estrogen receptor. And so now it's a cancerous cell. It's not a normal cell. It's rapidly dividing. It's doing things that, allow it to grow, invade local tissue, kind of recruit blood vessels, right? And so one of the ways that we can manipulate, kill, target that cancer cell is by targeting the estrogen receptor. So it's one of the tools. So I want, patients who have diagnosed with cancer, they understand there's lots of ways the oncologist tries to, treat their cancer. Lots of tools, right? They're going to target the cells by cutting it out, right? They'll have the breast surgeon cut it out, remove it. You have the radiation oncologists use radiation to impact the cell, right? We have things, you've heard of Herceptin maybe, or HER2 positive breast cancer. So that means there's receptors on those breast cancer cells that we can do targeted therapy like Herceptin. And with estrogen receptors, we can target it in a number of ways. We can lower estrogen levels. We can give medications like tamoxifen that don't actually lower estrogen levels. Tamoxifen blocks the receptor, so that receptor can't get any signals about growth, right? We can do something called, using aromatase inhibitors. So that is used for women who are in menopause naturally, or they got put into menopause surgically, or if they're younger, we can give them medications like Lupron or Zoladex, which quiet down the ovaries, stop your ovaries having estrogen production. And then aromatase inhibitors go in and further lower the estrogen even more, basically putting your estrogen like sub-physiologic, right? And so
like blocking testosterone to estrogen.
Yes,
what aromatase is doing.
That's what aromatase inhibitors is doing. So, so those are ways that we're manipulating the cancer cell. That is a very different idea than telling somebody or having this notion that estrogen caused your breast cancer. That's not true. And in fact, younger women, okay, so premenopausal women have a higher chance, they're the ones who are more likely to get triple negative breast cancer, okay? Which means those are breast cancer cells that have become so abnormal, so different looking than a normal breast cancer, than a normal cell, that they don't have any receptors to estrogen or to progesterone, right? So it's triple negative. So that's interesting. These are women, younger women are more likely to have triple negative breast cancer. So these are women who are bathed in estrogen, right? Every month, they're still getting their periods, but they're more likely to develop triple negative. And in fact, estrogen receptor positive breast cancer is more likely in the postmenopausal women, right? When they don't have estrogen around, right? And so why you get one form or another, we don't know exactly. Some genetic mutations may predispose women to certain types of, breast cancer, but we don't really know why anyone gets one form of breast cancer. And it's also important for listeners to know breast cancer is not one disease. It's many diseases. There's many different types of breast cancer and kind of permutations of like how that cancer expresses, whether it's triple negative, triple positive, ER/PR positive, HER2 negative. There's other markers that we look at. And so just like we treat any individual human being, we treat every breast cancer very specifically, and it's targeted and it's individualized. The reason why I'm making that point is breast cancer is not one disease. Like DCIS is not the same as advanced multiple positive lymph node triple negative breast cancer, for instance. We treat those very differently. So hence, follow me through on this. When women then, as a survivor, or they're in the middle of their breast cancer treatment, present with debilitating menopause symptoms, sexual symptoms, other side effects, we should not treat them with the same blank answer of, I can't do anything with you. We can't talk about any kind of hormones, or we don't have any strategies for menopause because you had breast cancer. We have to individualize it. But sadly, what happens is, and this gets back to the WHI in these fears that are ingrained, breast cancer estrogen, like literally that's the only thing that goes off in people's heads. So then when a breast cancer survivor presents and is seeking care for her estrogen deprivation symptoms, and that's what we have to call it, because these women are being put into a state of severe estrogen deprivation, either surgically or medically, chemotherapy, these medications like aromatase inhibitors and tamoxifen. We can't just knee-jerk say, sorry, like exercise and use some coconut oil. Like literally that's what they get. And here's an antidepressant. Like we need to be more nuanced. Just like we're nuanced in treating their cancer, we need to be nuanced in managing their long-term, estrogen deprivation symptoms, because goodness, obviously this is something I'm passionate about, but there's 4 million plus survivors of breast cancer in the US alone. Every year, roughly 300,000 new women are added to their ranks. Over 60,000 or more women are diagnosed with stage 0 DCIS breast cancer, and then even more are being diagnosed and screened for carrying like BRCA1 or 2 mutations or other hereditary mutations. And they're having ovaries removed early to prevent, ovarian cancer. So we have this kind of like ever-growing population of previvors and survivors. And we have to stop with this knee-jerk like reaction that we can't have any discussion of hormones after menopause with any of these women. I mean, it's unsustainable, frankly.
Yeah, that's a big population.
That's just in the US alone. I mean, women are suffering profoundly by the lack of individual nuanced menopause care after breast cancer or after being diagnosed with just being at high risk of breast cancer. Because, we're forgetting about we're talking about breast cancer survivors, but remember you get it all the time, I'm sure, questions. There's huge amounts of women who are at higher risk for breast cancer, right? They have a family history, they carry a mutation, or they have things like dense breasts, or they had, a benign breast biopsy that raises their risk of breast cancer, right? And so there's a huge population out there who is also not a cancer survivor, but they have a lot of fear about how do they navigate menopause and how do they address sexual symptoms and such. And so because the WHI fears and misinformation that were propagated, a lot of doctors don't even know how to deal with those patients, right? Which is, this is like becoming unacceptable.
So what is a breast cancer survivor or previvor, someone who has maybe a genetic predisposition like the BRCA1 or 2 mutation, as you were mentioning? How do we have that conversation with our oncologist? I know that there's going to be many women that are listening to this who either themselves are a survivor or they know someone in their family or friend circle, community who has survived breast cancer, and maybe they're going through having some of the signs and symptoms of menopause. Yeah. Would greatly benefit either to their quality of life, their activities of daily living, all of the things from hormone therapy. And their oncologist is just like, absolutely not. Like, this is just an absolute no. Like, how do we bridge that conversation with a doctor who may just be and not poo-pooing on oncologists. They're obviously just trying to do their job. They're trying to they're trying to reduce their risk of having a recurrence or a relapse. But how do we bridge the subject with them?
Such an important question. And so first of all, we have to respect what oncologists do every day is so incredibly hard. And, they're in the trenches taking care of both women who survive, but also women who have recurrences, and they see metastatic cancer and they see death from breast cancer. Over 40,000 women still die every year in the US of breast cancer. And so, and the oncology field is constantly changing. There's so much for them to stay up to date with. But we have to recognize that if the average OB-GYN has less than 4 hours of training in their residency in general menopause, do you think that oncologists or breast surgeons or radiation oncologists, do you think they have menopause training? No. So let's just recognize that doctors aren't trained in menopause, just plain old benign menopause, much less menopause after cancer. Okay, number one. Right. So we have to understand that's where we're starting from. And yes, there are some oncologists who are understanding of this, but the vast majority just have not been trained, just like the vast majority of OB-GYNs. And not only are they not trained in hormone therapy, what I find sadly is they're not even trained or really grasp the full extent of menopause. So when and we can get into my personal story if you want, but
yes,
in
I
a
would
little
love
bit,
to. Yes.
but we'll come back to it in a minute. But like when I was diagnosed, no one told me about the menopause symptoms that were to come. And most women who tell me, like, what guidance did you get from your breast cancer team, right? Because it's not just the oncologists, the breast cancer nurses and the surgeons and, everybody who's, and their GYNs. And they say, well, I might have some vaginal dryness and I might have some hot flashes, right? And night sweats. Like literally those are the two things. And to me, that's a huge disservice to not inform a woman of what is about to happen when she begins 5-10 years or a lifetime of estrogen deprivation. With not, and it may just be that you're going into menopause and we're not giving you further medications like aromatase inhibitors or tamoxifens. But the women who are prescribed those medications, their menopause is even more profound and really much more serious. And we really need to, inform these women that it's not just hot flashes and night sweats, it's an increased risk of cardiovascular disease, cognitive decline, obviously the bone loss, mental health impacts, insomnia, increase in anxiety. I mean, the list goes on. And so I think this first step in communicating with your oncology, your breast cancer team is to say like, hey, can we have a separate appointment? Because there's a lot to fit in. These doctors are all overworked and stretched for time, and say, all right, we're here for my checkup or my follow-up or, talking about my treatment or my chemo or this. I need a follow-up appointment so that we can discuss and you can inform me of what does it mean for me symptom-wise, as well as my health span, lifespan, chronic disease risks with menopause and breast cancer treatment. And what are you going to do to help mitigate some of those things if I truly can't take estrogen, right? And so we have to be honest with certain breast cancer patients. We may never consider adding back systemic hormones to them. We may add back local vaginal hormones, which we can talk about. There are lots of safety data showing that. But I always want women to first hear the message that if you can't use systemic hormones, you have to demand, how are you going to manage this beyond just giving me an antidepressant? Because that's all that they get these days. And the reality is we actually have a toolkit of non-hormonal things that can work from prescription standpoint, from lifestyle, diet, other alternative, complementary therapies that we can use. And then for some women, we can have a nuanced conversation of balancing risks versus benefits of adding back systemic hormone therapy at some point in time when they're done with their treatments, right? And so I advise women that you have to start by actually making sure you're being educated on what menopause is going to mean for you and your treatment, what treatment options you have that might help mitigate some of those, like tamoxifen versus aromatase inhibitors, or, kind of individualizing your treatment so you can manage it better. And then, what are you going to do about it? And if your oncologist can't explain that to you or doesn't know, then that's when you have to say, I respect that you don't know that. Can you please refer me to a menopause specialist or someone who is able to help me with this? Because they can't just tell you it's not acceptable and you can't accept that. So then what do you do when the problem is patients do this? They try to advocate and then they're met with like, sorry, like this is the best we can do. So then you really need to, unfortunately, with all the burden of being a breast cancer survivor, I always say, you're really worth it. You have to act like the CEO of your health. You have to come in prepared and educated. So I advise women that you really do have to do the work yourself and bring it to your physician and say, well, I've read the non-hormonal position statement from the Menopause Society, and I see there's not just an antidepressant, there's all these other medications that I can use to help me with my vasomotor symptoms. And I've read the position statements on treating the genital urinary syndrome of menopause in breast cancer survivors. And I can provide links to your listeners for these guidelines. I have a Google document, my link in bio, my Instagram, that's become very popular. And it's a Google document where I just keep on adding all of the studies that show the safety of vaginal hormones in breast cancer survivors, even ER positive, right? So you go with that and say, okay, well, I want to discuss this. And I'm happy to kind of report that this menopause movement is trickling down to breast cancer survivors. And just last month, I spoke with two esteemed breast oncologists and a fellow OB-GYN. We had over 200 medical professionals there. And we had a 2-evening session discussion about using hormone therapy after breast cancer. Which patients are candidates for it? How can we have shared decision-making on risks and benefits? And we reviewed, there's over 25 published studies of using hormone therapy after breast cancer. They're not perfect. Some of them are old, they're small. There's things you could pick apart in all of the studies. But it's a start. And so we reviewed all of that data. And the consensus was really refreshing. At the end of these 2 evening sessions that we did, I think we all felt together as oncologists and menopause specialists that we can have individual nuanced discussions. And it's not a one size fits all approach. I think the book Estrogen Matters they have a whole chapter on, Dr. Blooming, Dr. Tavers have a whole chapter on, reviewing those 25 studies. And I'd say there's more and more interest in how we can individualize this. Now, will every medical oncologist be open to hearing this? Probably not. But I say to the breast cancer survivor out there, you're worth at least, you are worth pushing and having the discussion. And I do see breast cancer survivors, and sometimes I tell them, for you, this is not the best choice. And that's okay. I'm going to help you manage your menopause in other ways. So I never want anybody to listen to me and think that like everybody after breast cancer, HRT, no problems. No, that's far from my message. But everybody after breast cancer deserves a conversation on how we're going to manage our menopause and that you do have options. And in the end, there's something called patient autonomy, body autonomy. It's your body, your choice. And you get to decide what risks you take. If your risk, say, of breast cancer recurrence is extremely low, you understand that the data suggests that it likely doesn't cause an increased risk of recurrence, but we don't know for sure. There are some studies that showed there was an increase of local breast cancer recurrence when women used HRT. But you can make that risk-benefit decision for yourself, just like we allow you to make that risk-benefit decision when you choose chemo or aromatase inhibitors or mastectomy versus lumpectomy or any other medical treatment in the world. We give you choice and informed consent. This should be no different. You're a big girl. You can interpret and understand the information when given to you in a clear manner and make decisions.
And you can let them write whatever they want in the chart. It's like you can take the drug, like you can make the decision to do the HRT or whatever it is, and you can let them write whatever they want in the chart, because I know they're going to say, well, we're going to write this in your chart, which I know can also be really scary. It's like, oh, okay, well, if you're going to write it in the chart, then.
Well, yeah. And so I say, listen, I've worked with oncologists and I'll say, listen, I had this patient, we did a very thorough, review of her history. She's tried XYZ. This hasn't worked. She's at this point in her survivorship. She's really suffering. And at this point, she's decided she'd like to try low dose, menopausal hormone therapy. We're going to start on this, and we'd like your input. And they may say, well, in general, I don't recommend this and I don't advise that. And I say, okay, we respect that. She's been informed. She's signed an informed consent. We're going to follow her closely. And in the end, this is the patient's decision, right? But I find that most of the time, patients are surprised when you are the squeaky wheel and you actually present in a clear manner your reasons for, what you're interested in pursuing, and you're well counseled and you sign informed consent. I'd say more times than not, I find the medical oncologist is willing to, have a discussion. They're not going to be the one to prescribe it. I don't want them to. I don't prescribe chemo. Like we all have,
Right.
I'm not doing knee
Right.
surgeries, right?
Right.
It's okay, and it's important for your oncologist to be part of the discussion and the team. And it's important for us to respect women's values, right? And
Yeah.
how they want to live.
So let's put on our clinical hats here, and maybe you can give me two different
Mm-hmm.
scenarios. We have a woman who has survived breast cancer. Maybe she's going through perimenopause, menopausal changes in mood, affect, sleep, all the things that we've been talking about. Maybe she's noticing some brain fog, memory issues, what have you, body composition issues. I'll ask you the same question, but in two different ways. The best candidate that you might say that would be a candidate for hormone replacement therapy, and then maybe, you mentioned sort of in passing, there are patients where you say, listen, this is not the best strategy for you.
Yeah.
So can you paint a picture of like best candidate in that scenario, worst candidate, or someone who you might advise like, hey, this might not be the best route for you?
Absolutely. So the best candidate would be, let's start with like easy things. You've had DCIS. You've had a bilateral mastectomy. You had no invasive disease. Your breast cancer, which some might not even call it breast cancer, stage 0 DCIS, it's pre-invasive, right, has been completely treated. Hormone deprivation, tamoxifen, aromatase inhibitors, that was not part of your treatment plan ever. Some of these women have their DCIS and they go on to have normal periods for a number of years and plenty of estrogen in their bodies. Now, suddenly they go through menopause and suddenly we can't discuss hormone therapy. So that's an easy example of someone who I think low-hanging fruit, right? We can talk about that. DCIS with the bilateral mastectomy, your lifetime risk of recurrence is not zero because theoretically there can still be breast cells that are left over. But particularly in BRCA negative patients who have had, like I said, the bilateral mastectomy, that risk is very, very low and and we have to think about the risk of not treating their symptoms, right? So that's one easy. Then we have, I'd say, then the other thing to think about is, did you complete your breast cancer treatment, right? So it's best for you to get treated for your breast cancer, right? And, whether, you were triple negative and you have to get through your chemotherapy, you finish that, or you're estrogen receptor positive and you've been recommended 5 years or 10 years of adjuvant endocrine therapy. And we can talk about how we navigate that. But ideally, you've completed your treatment and now we're kind of, all right, what's next, right? So that's important. And then I think we have to understand breast cancer is not an individual, it's not one disease, as we alluded to. So a triple negative breast cancer is most likely to recur in the first 5 years. And probably the recurrence risk peaks around 3 to 4 years. So when I am, counseling estrogen receptor negative patients, I say, for the first 3 to 5 year timeframe, we're going to be more cautious with you, right? Not because I actually personally think that giving her back a low dose of hormone therapy is necessarily going to cause a recurrence, but it certainly is going to complicate it in everybody's minds, right? And so that's a time where we're going to maybe be more cautious. We can certainly give her vaginal hormones for local vaginal estrogen treatment, and we would try to manage her menopause, non-hormonally. Although there are exceptions that can be made, right? A very low stage, low risk, triple negative patient who's maybe 3 years at this point. Some of these women are premenopausal. So I give an example. Here's a good example. One of my dear friends, and she's been on Instagram Lives with me, and she's very active out there publicly, so she won't mind me telling her story, but she had triple negative breast cancer at the age of 28. She had her chemotherapy. She went on, to have many years of normal menstrual periods, right? Because she was only 28 at diagnosis, right? She went on to even have a healthy twin pregnancy in her mid-30s. And then at right before age 40, she got her ovaries removed because she carries the BRCA1 gene. And suddenly, nobody would talk to her about hormones. Meanwhile, she had over 12 years of high levels of estrogen every month because she had monthly menstrual cycles. So now
And
that's just like nonsense, right? To deny her access. She had surgical menopause, and overnight her life changed, severe symptoms, severe sexual symptoms, hot flashes, night sweats, waking. So that is like a no-brainer example, right? Of where she should have access. Now, a trickier example where we're going to be more cautious is someone who is estrogen receptor positive, who, those women still can have the discussion, right? But we're going to think about it in a little bit more nuanced. We have to recognize that estrogen receptor positive breast cancer tends to be slower growing, and it is the one that can have late recurrences at 5 years, at 10 years, at even 20 years, right? So we have to tell these women, like, breast cancer can come back, even early stage ER positive breast cancer. The preponderance of those studies I mentioned show that even ER positive breast cancer, when we give them back hormone therapy in these studies, it doesn't appear to increase their risk of recurrence. But we don't have perfect studies on that. And there was one study that showed they had an increased risk of recurrence locally in their breast or to get a new primary in the other breast, right? And so those are the patients that were more nuanced. We want to look at, what is your absolute baseline risk of recurrence? Did you have extensive disease? How did you respond to therapy? But those patients can still have that conversation, right? So basically, in general, lower risk disease, estrogen receptor negative, outside of that first 3 to 5 years. Those are like, kind of general ideas. And then women who are in the middle of breast cancer treatment, ER positive breast cancer patients, these are tricky, right? Because they may have 5 to 10 years where the oncologist is recommending things like aromatase inhibitors or tamoxifen. And so the way I approach that patient is different, right? They're still in the middle of treatment. So we have to individualize it. We want to make sure that she's actually getting a lot of benefit from her adjuvant endocrine therapy and weighing the benefits versus risks. So an example I give here is someone who's completed 4 years of the aromatase inhibitor. They were a stage 1A breast cancer. They have low risk of recurrence, and they are debilitated by the aromatase inhibitor. It's reasonable to talk to them about individualizing their treatment, changing to tamoxifen, taking a drug holiday, discussing with the oncologist if the benefits aren't really outweighing the risks of the detriment to her quality of life, right? So sometimes the treatment for their menopause symptoms is to reevaluate the need for their estrogen deprivation. Now, other patients might come to me and they're at, say, 4 years of tamoxifen aromatase inhibitor, but they had a large tumor with multiple lymph nodes and other markers of a higher risk of recurrence. I'm going to kind of help them manage things in a different way, right? And so I think sometimes the answer is kind of just individualizing their treatments and recognizing that these treatments have really serious side effects. And in fact, up to 50% of women quit tamoxifen and aromatase inhibitors because no one is addressing their side effects. And sometimes just addressing side effects allows them to stay on these medications. But when we don't recognize the menopausal side effects for what they are, it's very hard for these women to get adequate care, right?
And I think it's also, just quickly, I think tamoxifen is, it's worth noting that it's not an estrogen blocker, is it? My understanding is that it's more it has more of an anti-tumor effect than it does blocking estrogen. Can you clarify that?
Yeah, I mean, I think tamoxifen is a fascinating drug. It's a selective estrogen receptor modulator. So in some tissue, it blocks the estrogen receptor. In other tissue, it actually promotes the estrogen receptor. But one thing it doesn't do is tamoxifen doesn't lower your estrogen levels, okay? In fact, premenopausal women who use tamoxifen have higher levels of estrogen circulating in their body for the most part, right? So it's just competing with estrogen at the receptor level, right? And so it's not blocking the production of estrogen, right? And that's important, right? Because it's so silly that we deny women access to local vaginal estrogen to treat vaginal atrophy, painful sex, urinary symptoms, they are on tamoxifen. It is a medication that is blocking the receptor in the breast. We use tamoxifen in premenopausal women, and we use it in these women without estrogen suppression. So we can give it, it's like a low risk for recurrence breast cancer patient who's, say, 40 years old. She still has her period. She's still getting periods. We give her tamoxifen without suppressing her ovaries. We don't also put her into medical menopause. So she gets her ups and downs of her periods. She's got estrogen being produced, but tamoxifen is there and is blocking estrogen receptors. And tamoxifen works in like 10 other ways. If you read about it, there's all sorts of immune impacts that tamoxifen has. It's actually fascinating. And actually, people who actually understand tamoxifen understand that that's probably one of the more important ways that tamoxifen works rather than just the estrogen receptor, blocker. And so I use it as an example of these premenopausal women because they have plenty of estrogen in their bodies. So if they're suffering from some vaginal dryness, you can give them vaginal estrogen, right? There's a lot of, misconceptions about tamoxifen. And I also want to just say that some women can manage tamoxifen okay and aromatase inhibitors okay with help. So if you're out there hearing this and you're about to start this medication and you're afraid to start it, I'd say don't be afraid to start it. It's an important part of cancer treatments, but don't be afraid to be a squeaky wheel and say, I'm going to start this, but I want help. And I want you to recognize that these side effects are going to happen to me. And I know I can have vaginal estrogen. And I know there are things you can do to help me with my hot flashes and night sweats and other symptoms. So don't throw me to the wolves.
I want to move to vaginal estrogen, but I just have one question that, as you were talking, I was thinking is when we're thinking about these ER positive cancers, are we also, and maybe for all cancers, whether they're ER positive, negative, progesterone receptor positive or negative, do we take lifetime exposure of estrogen into account when we're thinking about who may or may not be a candidate for hormone replacement therapy? So, for example, if someone suffered for years, let's say with PCOS, maybe they're put on the birth control pill to control it, but it never actually really fixed they were, or whether or not the birth control pill is in the picture or not, that PCOS where they've had years or months, at least months of anovulatory cycles where they've had a lot of exposure maybe to estrogen in the absence of progesterone, let's say. Or if someone is obese, of course, we know that adipose tissue is not just like annoying, subcutaneous fat. It's an endocrine organ where we know that there is production of estrogens, right? So, estrone, but estrogens. Do we take that into account when we're thinking about the prognosis or whether somebody is a candidate for HRT as well?
I would not use it. There's no guidance out there that says lifetime exposure to estrogen might preclude you from being offered safe menopausal hormone therapy to treat your menopause symptoms. I think, and this is a bigger discussion, I think these risk calculators that are very overly simplified, where they only take into account your periods, when you went through menopause, how many babies you had if you breastfed, and they don't take into account things like alcohol intake or family history or genetic status or
metabolic health.
Yeah. And I actually think this I think it's totally oversimplified. And I think this idea that people with obesity have a higher risk of breast cancer because they're more estrogenic is really way oversimplifying. What you alluded to really is what is really happening in people living with or struggling with obesity is profound metabolic dysfunction, inflammation, and the impact
systemic
inflammation that has insulin resistance and all of these things have on cancer development, on immune function, on cellular repair. And to break it down to estrogen exposure or not is really way oversimplified. And I think
missing the boat almost.
It's missing the boat. Yeah, it's missing the boat. And so I don't really love the breast cancer risk assessment tools that are overly simplified. I think you can use them, like the Gale model, for instance. It could be a useful starting point, perhaps, but you need to look at the woman's whole picture. And I think it's really important for women to know their risk of breast cancer. By the age of 30, all women should have a basic risk assessment. Why? Because it's a great opportunity, one, to talk to women about modifiable risk factors, like how we can, improve their overall, health and risk reduction for not just breast cancer, but other cancers with obviously lifestyle and exercise and diet modification, but also helps identify which women might be referred for genetic screening, right, for hereditary cancer, and which women might be good candidates for enhanced surveillance. Because we don't treat all breast cancer the same ways, and we shouldn't be doing breast cancer, screening as a one size fits all. There are some women who need more intensive screening, and there's some women who need more like average screening, right? Your audience should note there's a wonderful study called the Wisdom Study. It's a nationwide study. It's free. Anybody can participate. I think starting at age 30, I think. And basically, you put in all this history and they do a risk assessment. You get a free genetic test for it. And then they give you their recommendations for screening for you. So that's important, but none of that should preclude whether you get hormone therapy or not. So my example is you have a higher risk of breast cancer because you have a strong family history, say, and you have dense breasts. So your risk is here versus the average risk, which is lower. Giving hormone therapy for the appropriate reasons, right? For symptom relief, for the prevention of osteoporosis, right? Does not further increase your risk. Okay. Your risk is still elevated. And I want to know about that elevated risk so we can screen you and, talk to you about lowering your risk in terms of other lifestyle things. But it's not going to stop me from giving you hormone therapy. And that's what the Menopause Society position statement clearly states. Yet, let's get back to the pink elephant in the room. The fear of breast cancer precludes those women from getting access to hormone therapy because there's a knee-jerk reaction. The OB-GYN, the primary care doctor says, oh, you're crazy for doing this. You have a family history of breast cancer. We can't give that to you. And I'm like, did you actually ever read any of the science or the data or the recommendations? Which it's not true, right? And then one step further, BRCA carriers. So women who carry the mutation, who have not had breast cancer, who choose to take their ovaries out to lower their risk of ovarian cancer. And there's thousands of these women now, right? Tens of thousands, hundreds of thousands, millions of these women who lose their ovaries before the age of natural menopause, right? So their ovaries are coming out before age 45, before age 40, sometimes younger. And they're in surgical menopause, premature surgical menopause. Very high risks of cardiovascular disease, diabetes, cognitive decline. These women need hormone therapy given back. And in the past, and still many people, knee-jerk reaction, you're a BRCA carrier, we absolutely can't give it to you. But even in women who have not had their breasts removed prophylactically, even in these women who are BRCA carriers who have their ovaries removed, they can safely be given back menopausal hormone therapy, at least up to the age of natural menopause, and then at that point beyond, because it does not appear to further increase their risk, and it doesn't negate the risk reduction that having those ovaries removed gave them. So, so I always tell women, so we have clear clinical guidelines, published guidelines that BRCA carriers can have hormone therapy. So don't tell me you as an average risk woman or someone who is not a carrier should be denied it, because we're giving it to the most high risk women.
All right, let's talk about vaginal estrogen. Why should every woman be thinking about vaginal estrogen as whether they're sexually active or not? Why do we want to be thinking about the genital urinary syndrome of menopause, and why is it important? Maybe actually let's just define GSM for the listeners, and then we can move into vaginal estrogen.
Perfect. So GSM, genital urinary syndrome of menopause, it's more than vaginal dryness. So basically when estrogen levels decline, due to menopause, for whatever reason, you're in menopause, natural, surgical, premature, you have a loss of estrogen at the tissue level of the vulva, the vagina, the labia, the clitoris, the urethra, and your bladder. And so with the loss of estrogen, and I use the example of the skin on our face as we age, right? It gets drier, it gets thinner, more wrinkles, it's less elastic, less moisturized. Well, the same thing is happening in all of those tissues that I just named. Loss of collagen, loss of support tissue, loss of blood vessels there, and less sensation, changes in the nerve endings. And so it's a syndrome that is not only going to cause, dryness and decreased lubrication, but also urinary health. So increase in urinary urgency, frequency, increased risk of urinary tract infections. Okay. So if you are like, okay, I'm menopausal, I'm noticing some vaginal dryness, but it's not really bothering me. I'm not sexually active. I'm not having pain with sex. I'm not going to do anything about it. It's really important for women to know GSM basically affects all women going through menopause at some point in time. Some women have more of a pronounced effect than others, but it's progressive. So that's an important thing for listeners to know. It's not something like that you just kind of get over. There's a progressive decline in the tissue quality. So you might not be sexually active right now, and you might not be having any symptoms now. But at some point in time, you are going to be at risk as you get older for all of these urinary symptoms, urinary incontinence, urgency, frequency, UTIs. And the number one reason why women who are older wind up at urgent care, emergency room, is for urinary symptoms, urinary tract infections, which then can become a kidney infection, can lead to sepsis, pneumonia. You can have cognitive changes when you're having an infection. You could slip and fall and break a hip. I know it sounds like outrageous to say it, but it's actually just true. And so I like to think of it as just preventative skincare for the vaginal skin, as well as the skin, quote unquote, of, the urethra, and the lining of your bladder. And so just from a preventative standpoint, as we age, I think personally all women should be on, vaginal estrogen. And it's really safe to start it if you are hearing this message for the first time and you're 70 or you're 80 or you're whatever age, and you either are having symptoms or you want to prevent them. The thing about GSM is it's treated with local vaginal hormones. We don't need to do systemic hormone therapy for these women, that the local hormones work really, really well. And even if you've had a lot of decline in either sexual function, urinary function, symptoms, we can really get it back. We really, really can. I've seen women who had terrible symptoms, and, consistent use is really safe, really effective. And there is really hardly any contraindications out there. I don't care whether you had a stroke, a massive heart attack. I don't care if you have advanced breast cancer. I don't care if you had ovarian cancer or lung cancer or colon cancer. We can give you back. I don't care if you've had a history of blood clots. We can give you vaginal hormones. There are a few rare sarcomas, some certain advanced GYN cancers that we might be slightly more cautious with. Or if you are on an aromatase inhibitor, there's certain vaginal estrogen formulations and instructions on how I would have you use it. But outside of those circumstances, everybody can have it.
I love that you're saying this, because I think that a lot of women will say, oh, well, I'm not sexually active, or maybe I am sexually active and I'm using lube, so isn't it just fine? And we've had, obviously, Kelly Casperson's been on the show, and I'm going to quote her here because she needs her own Netflix special because she's so comedic in her delivery. But she said something like, do your orgasms feel like,
Exactly.
Like you have, in order to get there, it's like you're, masturbating or self-pleasuring like through a blanket, because if it is, or a Kafkan or something, I can't remember what she said, but it's something like that. If it feels like your orgasms or your tissue sensation is changing. And I think the stat that she dropped on the show was like 80% of women will experience some degree of clitoral atrophy, which is, I had to pull my mouth, like my jaw was on the floor when she dropped that. And she's like, and I actually think it's higher because we don't actually track it, because it's so cloaked in shame that we don't even talk about it. So it's sexually active or not, lube user or not, this is going to, and to your point, this can lead to, in the extreme, sepsis. Like, this can literally kill you.
Yes.
I think it's important. I think it's so important, some of the points that you made around it being progressive, like this GSM.
It is progressive.
As you are estrogen deficient, it just gets worse over time. The tissue gets thinner and thinner over time. The atrophy continues over and over. And I think that this works really well into sort of this like timing hypothesis, because a lot of women will say, oh, well, I missed the window. Like I was menopausal in like, 2020, 2004 or 2002 or whatever, I was denied hormones. So now I'm 70, now I'm 75. Can I still take it? And this is one of the ways that we can potentially alleviate and improve a woman's quality of life, irrespective of her age.
Yes. And
Correct?
I think absolutely. I mean, yes to everything you just said. And this is why when we only talk about it as vaginal dryness, we're doing women a disservice. About a year ago, I was on Dr. Mary Claire Haver's Menopause cruise. It was so much fun. And we had a bunch of experts, and we had amazing women that we got to hear from. And there was a lawyer who was on the cruise. And she said, you know what? I've been a divorce lawyer for over 30 years. And she says, honestly, and I don't want anybody to be offended by me saying this, and part of her was joking, but not joking. She goes, if vaginal estrogen was routinely handed out and discussed with perimenopausal women, I think that half of the divorces would have been saved, because it's a really slippery slope. And so, let's paint this picture of a 40-something-year-old woman who's been juggling life pretty well, had a relatively happy marriage. We all know, marriage is not easy. But over the last few years, not only does she have all these like vasomotor symptoms and hot flashes and insomnia, she feels more anxious, put on weight gain, her body's changed. Her doctor says there's something I can do with you. You're not menopausal yet. And, and the husband is getting ED meds because 50% of men have erectile dysfunction by the time they're 50. So the husband's penis is optimized.
Ready to go. He's ready to go.
And as Kelly says, is anybody asking the partners of these men with these, really robust erections, how the recipient of that penis feels, right? And so if your tissue is, all right, you take care of the dryness, you use lube, you're able to get through the act, you have sex, but it's a blood flow issue. Erectile dysfunction meds give enhanced blood flow to the penis. It helps make it erect. Guess what helps blood flow to the clitoris? Vaginal estrogen. Rachel Rubin, amazing doctor you have to follow, and she's amazing. She talks about, vaginal estrogen being kind of like Viagra for women, kind of in a backdoor way, and that vaginal estrogen improves tissue quality, keeps it thicker, more blood flow to the clitoris, less atrophy. So then the sensation is good. So now maybe that woman not only just tolerates sex, but actually wants it, because your brain does not want something that feels
that hurts.
Not even hurts, but just feels like mid, right? As the teens say, right?
As my 14-year-old boy was like, that's mid.
And so you don't crave mid sex, especially when you're having hot flashes at night, sweats and you're tired, you just want to pass out at night, right? And so you could see how this can create a lot of tension in a relationship, because the husband perceives the wife as not desiring him and not wanting to be in it. Her brain is just not motivated, because your brain is only motivated by things that feel really good. And what I find is women forget what sex is supposed to feel like, because they're in long-term relationships, say, and they kind of got used to it just being kind of blah. And let's also remember that a large number of perimenopausal women are put on birth control pills to manage, obviously, contraception, which is great. I prescribe birth control pills all the time. I'm not against them. But birth control pills, one of the side effects is vaginal dryness and lowering testosterone levels. So a known side effect of birth control pills is lower libido. A known side effect is vaginal dryness. And so here we have a perfect storm. We've got a woman who has lower libido because she's also probably been put on Prozac or an SSRI, which we know has sexual side effects. So she's on the SSRI and the birth control pill. No one offers her vaginal estrogen, which is safe to take with both of those things, by the way. Her husband is on ED meds, and she's also not sleeping. So you can really see these ripple effects. And that's why vaginal estrogen is so important and empowering. But, because it's shrouded with shame and fear and all these misconceptions, there are lots of doctors out there who literally don't even know how to prescribe vaginal estrogen. And they think a family history of breast cancer, or because she has some other medical complication that she can't use it, right? And so then take it a step further and you can see the devastating effect that breast cancer treatments have on women's relationships with their sexual partners, their sense of intimacy. And when we deny even discussion about vaginal hormones in breast cancer survivors, these are women who are already struggling with all sorts of sexual and body image issues and loss of, you know, loss of everything, right? I mean, there's so much going on here that when we tell these women that just lube and coconut oil is what they need to stick with, meanwhile, they have profound clitoral atrophy from aromatase inhibitors. It's one of the main side effects that no one informs these women on. And I don't want to say be afraid to take these medications. You can take them, and we have ways to help treat and prevent that downward decline of your sexual health, even if we're not doing systemic hormones. So like my favorite thing, I can talk about vaginal estrogen all day because there's really so many people who everyone's a candidate and there's so many more ways it helps besides just vaginal dryness. And when you give women with breast cancer some control of one aspect of her health, because everything's been taken out of her control, don't discount the power of that. Meaning, like, I see women who have horrid menopausal symptoms, and I say, okay, let's pick one or two things and let's work on that. And it may not be that I'm giving you HRT back yet, you know, but just the power of a little vaginal estrogen can give her hope back and intimacy and some control of her body. And maybe she won't be peeing 5 times, you know, at night and be woken up. Like, there's so many profound ways that we can help these women, but they're not being helped.
I struggle with this too, because I think that talking about sexual health for women still very, very shameful. Like, you know, you mentioned that we were talking before about incontinence, like urge incontinence and frequency. And I think that nobody, you know, it's like, you don't want to end up in diapers, right? Like, you have to, this is something that we just have to just get rid of the shame.
Men aren't embarrassed. I mean, for God's sake, they all get ED medications like it's going out of style. It's easy for them to get testosterone as well for their low libido. You know, those are easy, and it's not shameful. It's kind of like, okay, I'm staying robust and manly as I age, and that's cool. And our medical world supports that, right?
Yeah.
But
so how can we make it cool for women?
Well, it's becoming cool. It's getting there, but we just need to level up the clinicians' knowledge, because we now have women who are demanding access to care, and we have clinicians who are prepared to give it. There's a mismatch there. And so that's why you and I do podcasts, right? To get the message out. Anybody listening, I have a course for physicians and clinicians who take care of breast cancer survivors on managing menopause and how to prescribe them hormone therapy or make those decisions. So I'm doing like CME classes. I think that's like a step in the right direction. And there's more and more doctors who are interested in that. And I think all of us out there speaking at professional medical societies and conferences, because really, I think the solution is we really need to level up the education of the clinician at this point, because, you know, the word's getting out on the street to the women, but they're kind of faced with not getting access to care, right? That's a big problem.
So in wrapping this up, I wanted for you to share part of your story, or however much you would like to share with our listeners. You are obviously a breast cancer survivor. Tell us a little bit about what happened with you, what interventions you were offered, what you ended up doing about it, and where you are. I mean, obviously you're still here with us today, thank goodness, but tell us a little bit about you.
So in 2001, I was a second year OB-GYN resident. I was newly married. I was 28 years old. We had no family history of breast or ovarian cancer. And my mom died of stage 4 ovarian cancer. Suddenly, it's a terrible story, but she died. And 6 weeks later, I was diagnosed with breast cancer. Right before her death, I had felt a small lump in my breast and was dismissed. I dismissed myself. I was like, I'm too young for breast cancer. We have no family history of breast cancer. My physicians who I was training with, as well as my GYN, they all said, just watch and wait for a couple of cycles. You're too young, which my first experience of being gaslit and dismissed. But then fast forward, right after my mom died, I was like, I got to get this checked out. So I was diagnosed with ER positive, HER2 negative, stage 2A breast cancer. Very devastating because I was, we were thinking about starting a family, getting pregnant. I was in the middle of my medical training. But I went ahead and wound up getting through multiple surgeries, wound up getting eventually a bilateral mastectomy. I went through 6 months of chemotherapy with some hormone suppression. I did fertility preservation prior to starting chemotherapy in case chemo, killed my ovaries, which it didn't. Then was on tamoxifen for a few years and then paused my tamoxifen, was able to have a natural pregnancy. I have a almost 21-year-old beautiful daughter. Went back on tamoxifen with some ovarian suppression for a period of time, but that was really, really rough. Then
And that was for reoccurrence? What was the reason for
no,
getting back on it?
no. So positive breast cancer, the standard of care is 10 years of adjuvant endocrine therapy. So I was able to do tamoxifen for a couple of years, and we support women. This is interesting. This is a whole nother podcast, but we support women who are breast cancer survivors who are even positive people to pause their adjuvant endocrine therapy, which can be for up to 10 years, to get pregnant. So I was young. So they said, okay, you could stop everything, get pregnant, have lots of estrogen, right? Deliver a healthy baby. And then I went back on tamoxifen to finish these 10 years. And so I realized early on that I was not prepared as an OB-GYN to even understand or treat my own now severe, abrupt surgical, or at first medical menopause, and then subsequently down the road, I had my ovaries removed, then surgical menopause. I had no idea how to treat myself with all my awful symptoms, much less the average menopausal woman. So that kind of personal experience got me involved in the Menopause Society, and I continued, to focus my practice on that. And it really evolved over time. So I tell patients for literally almost 18 years or more, almost 20 years, I managed horrific menopause symptoms, sexual side effects, the whole thing, really without much help. I mean, because I was a bad menopause doctor, right? Because I was not trained, right? And then even after I got trained in managing other people's menopause, I still had a lot of fear about how to deal with my own. And so I did not do anything optimally. I didn't do things the way I would have, all the stuff I talked about today. So it took me a really long time to get to a place where I treated myself.
I always say, bless my first patients for letting me practice on them.
Yeah, exactly. Yes, exactly. Yeah. And so it took, a long time. So I really relate to women who have been dismissed, been gaslit, who didn't, get proper care. And I buried my head in the sand in terms of the sexual side effects and all of the kind of quality of life side effects. And so along the way, I found non-hormonal things that helped to a point, lifestyle things that I should have done earlier, right? And then finally, after many, 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 many years, I, made the decision, actually with the support of my medical oncologist, to start hormone therapy. So I've personally experienced what it's been like to be a late start. I was past the 10-year window by far. And I have started very low dose, not very high dose, low dose transdermal estradiol, progesterone at bedtime. I added in testosterone eventually for libido. Game changer.
And
game changer.
Game changer. I was gonna say, how did all those things? How did you feel? Was it night and day
Night
from getting
and
the estrogen?
So I'll say, and again, my choice is not for everybody. And I did it in lots of ways. And I think that you don't have to do what I'm doing. But, when I speak about this and making these hard decisions, I speak from personal experience, right? And I second guess myself through the years, and it's been messy and not easy. So there is no one clear path. But I will tell you, what was the most devastating looking back at all those years was the loss of sleep, years and years of chronic insomnia, terrible nighttime hot flashes that really nothing, antidepressants through the years helped, effects I was on for a long time. Once I was able to restart, I started with nightly progesterone, and then I added back really the lowest dose. I'm on like 1 to 2 sprays of Evamist, very, very low dose. My serum estradiol level is around 35, very low. But for me, that's all I need to have relief of my symptoms. So it's very low dose. Within a few days of progesterone and the estrogen, it was like an aha moment. I finally slept through the night. That kind of low grade anxious feeling, little, common heart palpitations, the hot flashes, the night sweats, they went away. I had more energy. My joint pain improved. I mean, I had tried all the things and was doing exercise and all those things, and it helped. But I will say I noticed a big difference. I was really lazy about using vaginal estrogen, and then I got better at it. And after a few weeks, game changer in terms of sexual function as well as urinary symptoms. And then after a period of time and learning more and getting more educated on sexual health, being part of ISHWISH, the Menopause Society, decided, all right, I had my ovaries removed years ago. My testosterone level was 2, very, very, very low. And I just didn't have drive or interest, and sexual response or orgasm was definitely not what it used to be. And so I added back very low, very conservative, using the ISHWISH Global Position Statement Guidelines. And I'd say I had a response very early. Some patients, it can take 6 to 12 weeks to notice a response and desire. For me, it was a huge game changer in overall sexual function, from arousal to desire to interest to performance and function. So that was really life-changing for me personally. And I think that the lessons I learned from just being my own patient is that it really can have huge improvements in quality of life. And it is more than just vaginal dryness and hot flashes and night sweats. And I think that you can take all those tools, and some women only need one thing, or they need the whole kitchen sink. And looking back, when I did use non-hormonal things for my hot flashes, it did help me. I wish I had investigated all the different non-hormonals, because there are more than just antidepressants to use. We've got other, prescription medications that we can use, and Veoza is a new medication on the market that can be helpful. So I'm very optimistic that we do have non-hormonal things for hot flashes and night sweats. And I didn't always use them. And in retrospect, treating those things and sleeping through the night is really damn important, because you can't do the lifestyle things that we ask you to do as a cancer survivor unless you're sleeping and having those things controlled. So don't be afraid to do something, even if it's non-hormonal. And I really wish I would have years ago consistently used vaginal estrogen. And I also really, really wish years ago someone would have educated me and I would have been up to date on adding back in low level of testosterone. And an example, mine was 2. And when I checked it recently, my testosterone level is 17. It's crazy low. Okay. Mm-hmm. But let me tell you, I'm a responder. I don't need high levels.
Yeah.
I just a little bit on my little starve receptors. I think just it has a profound impact on me. I notice a profound difference. And so it's not about chasing down a blood level. The guidelines are clear when it comes to testosterone. We can find the balance of, giving back. We start with low transdermal doses, and we find, do you get a response? And do I care what my number is per se? I don't need it to be super high. It's working for me. Other women need it to be a little bit higher. They may start at 20. And so when we get theirs to 50 or 60, they feel better, right? But for me, I use an example is I'm using very modest doses and I feel really good on them. So that's my little personal thing.
I love it. I love it. And I have to thank you for sharing that, because, your honesty and your transparency, there will be other women who are listening who are going to see themselves in you. And this is the value of being, you mentioned a couple of times, so I'll just reflect it back to you, being that squeaky clean, advocate for yourself, learning all of these things. And certainly you can have regrets, but I would love to reframe it as that was your path. That was whatever it was supposed to be, was what happened for you, and now you can take what you've learned and the contrast, right? Sometimes we need that contrast. We need the crescendo of the play, along with the very soft melodic parts of a music piece, let's say.
Yes.
We need the night and day contrast in order to understand how truly valuable, like you said, sleep is, to be able to show up and do some of the things that you need to in order to live well. And now I think and I've seen you do this. I've seen you walking walking on your treadmill on Instagram. Like I see you advocating and doing all the things. And I don't think that would have been possible if you didn't have the experience that you have or had. And I think that, you did not disappoint. This has been such a fantastic conversation. I'm so happy that you came on. And I know that this is going to help so many of my listeners to have better conversations with their PCPs, with their primary healthcare providers, and to make better decisions for themselves. So I just can't thank you enough.
Thank you. And I want to give my favorite resource shout out is Menopause and Cancer. So if you're a cancer survivor of any type, my dear friend Danny in the UK, she has an incredible podcast, an incredible website, free resources for all cancer survivors, menopauseandcancer.org. There's incredible resources on hormone therapy after breast cancer, as well as vaginal hormones and breast cancer. So if you're needing to listen and read and hear these stories, I think that's an incredible source. So I always want to, shout out to her, because I know women who have had cancer, no matter how many podcasts they hear, they still are just desperate for more information, right? Really, really important. And also, just understand that if you are getting, a brick wall when you're trying to get answers for, hormone therapy, know that there are educated clinicians out there. This is why I do telehealth. I'm a medical advisor at Alloy, and we see patients there, and we're physicians who are trained in menopause. And so I think, don't let yourself be limited if your in-person GYN who you loved and has served you well for the years is just not up to par when it comes to the menopause piece. It's okay to seek a second opinion because you're worth it. So speak up, be a squeaky wheel.
Fantastic. Thank you so much. And we'll make sure that all those are in the show notes as well.
Amazing. Thank you so much for having me.
You are so welcome. Hey, if you're listening this long into the podcast, welcome to the Betty After Party, where I tell you what I loved or didn't love about this conversation. So a couple things here. I thought that first, I loved Corinne's explanation of the WHI. She actually got into quite a bit of detail with the two arms of the study, the estrogen only and the estrogen plus progestin study, which is not something we've actually discussed on the show before. So it actually added a little bit more nuance and a little bit more color as to why people were freaking out over the estrogen only arm or the estrogen and progestin, arm of the show or of the study. There were a couple of big highlights for me in this entire conversation. First and foremost, obviously, we spent most of our time talking about breast cancer, and I really love this idea that just because you've had breast cancer, irrespective of the type, because we know that breast cancer is not just one thing, it can be many things, just like menopause can be many things. That you at least deserve the opportunity to have the discussion with your primary healthcare provider or several healthcare providers, your oncologist, maybe a menopause specialist, your primary, your medical practitioner, whomever, a naturopathic doctor. I think that this is an important how should we say it, taking back of our power. Whereas I think in past years and decades, we just sort of delegated like whatever the doctor said is what we did. I think it's important for us to be going at a squeaky clean wheel, as she was referring to a couple of times in the show, going and saying, hey, I've read the position statement. Hey, can I have this conversation? So I really, really love that. And maybe my most favorite part of our conversation was this idea that vaginal estrogen is like skincare. Right? We've seen people, myself included, using vaginal estrogen on the face for the anti-aging properties that it has. And why don't we use this for every woman in perimenopause and menopause, like there's so few contraindications to vaginal estrogen. It's not systemic. It's very local. And I loved that she talked about this idea that it's not just lube. Like we're not just taking vaginal estrogen just for lube. Like you can just use coconut oil for that, right? It's really about overall health of your vagina, your vulva, your clitoris, the labia, all of the anatomical parts that are literally starved of estrogen that gets progressively worse. It doesn't get better with time. It gets worse. So I loved that she talked about that and thinking about vaginal estrogen, in the extreme as something that can be possibly life-saving. Like we don't want more UTIs. Like I can tell you, I've never had a UTI, but I know I've had friends who've had UTIs and it's just the worst. So can we prevent UTIs? Yes. Can we avoid getting a kidney infection and eventually sepsis? Yes. So vaginal estrogen, FTW for the win. And then the other piece that I thought was really important was this idea of, hey, guys are getting, at least they have easier access to therapies for sexual dysfunction. So maybe they're being given Viagra or something that's going to improve blood flow to the penis. And now we have a very happy penis. Is there, I'm totally getting explicit, by the way, on this particular episode. But, we have a very happy penis, but is there a way to also have the recipient of that penis also very happy and excited for what's about to happen, right? She mentioned there was a lawyer on a cruise that she went on, a divorce lawyer, who said, I wonder how many divorces could have been avoided if we just gave these women vaginal estrogen. Like, just imagine that. And Corinne did a really good job of painting that picture. We have like a really excited guy ready to be with his wife, and the wife has like brain fog. She's not sleeping. It hurts when they have sex. Can we just allow our women the same access to care as we are our beautiful men? Like, both are beautiful women and men getting the same access to care. And then, low divorce rates, right? And the sort of socioeconomic changes that can come with it. That was such a great conversation. As I mentioned, I met her at a conference that we were both speaking at, and I knew I wanted her on the show. I have included all of the show notes for you, clickable links, all the resources for her. She's a wealth of knowledge, and I'm so glad that you stayed to the after party to get the Easter egg that we kind of put in every show. So if you are a dark roast Betty, you're probably listening. Thank you so much. I hope you appreciated it. Let me know in any of the reviews that you give, whether it's iTunes or you want to make a comment on Spotify. Love to hear from my Betty community. And until next time.